Right, I think we're going to go ahead and get started. Please continue to enjoy your lunch if you are in the middle of that while we jump into our Dean Speaker keynote and discussion. Again, I'm Brad Stotts, Faculty Director for the Center for the Business of Health, and thrilled to be joined by Nate Holobinko. Nate is a managing director and senior partner at Boston Consulting Group, where he is North America leader for payers, providers, systems, and services. So great individual to come and have a conversation about strategic workforce. Prior to that role, he led BCG's Western U.S. healthcare practice and has spent over 2 decades in the consulting space. We are also very proud to claim him as an alumnus of our undergraduate business program here at Carolina. So thrilled to welcome you home, Nate. Thanks for joining.
Thanks so much, Brad. It's awesome to be here.
Okay, great. Well, really what we want to do is just have a bit of a conversation, thinking about, over the course of the day, we've seen a bunch of different elements of strategic workforce. And so, you are well positioned as someone who has been working in healthcare consulting across a number of different parts for many years. And so could you talk a little bit about how you see kind of the current healthcare workforce evolving and the challenges that are out there right now?
Yeah, it's in my job, I have the privilege of getting to work, as you mentioned in my title, kind of across the sectors, which not all of us in this industry get to do, and it's kind of a privilege because I get to talk with the CEOs and C-suites of heads of hospital systems, of insurance companies, of the folks that provide services to them, and so really getting this kind of interesting 360 view because, at any point in time, in the space, you'll get very different perspectives from those leaders depending on where we are in the macroeconomic cycle. And at the risk of being a little bit cheesy, although my old English professors here might be proud of me, like it's sort of like the best of times and the worst of times right now, right? The best of times in the sense of there's just some really cool stuff that's going on in terms of the advancement of therapeutics right now and the power that's having. And like I've had family members who are alive who wouldn't have been alive a decade ago because of that. Things like checkpoint inhibitors, gene therapies, CAR T and these advancing cell therapies, and the whole world of operations that we didn't used to have the ability to do, and like that's amazing. We're also living in this really cool world of this is like also a little cliched because every 5-year increment of my career, it's always like, this is it. We're about to do value-based healthcare. It's happening. Like right now, we feel it. We're there. And like maybe now it sort of is. Like you can really see that the dialogue on that is shifting and like the emphasis on outcomes and economics, but just because of the raw pressures is shifting. So that's all really cool and amazing. The flip side, and I'm sure you've heard this in other conversations today, you go talk to the folks that are working in healthcare, and it's not fun right now. Like the workload is really, really hard and it's high, and the pressures of those things that I've just talked about are exacerbating that. And I think we're in a place where we would have gotten to where we are today in terms of this pressure without COVID, but COVID really accelerated that, right? We're at this wild demographic inflection, and I think this is the root cause of a lot of our challenges right now. So many of our physicians, nurses, administrators are reaching Medicare age, and they're at the age where they're naturally coming out of the system themselves, and they're becoming patients at the same time that they're leaving the system. And so the demand is rising, the workforce is shrinking in the near term, while our expectations as patients are all rising. And by the way, we've done these other things over the past couple decades where we've expanded Medicaid, we've expanded the individual insurance, and so there's more patients in the system than ever that have access, which again, many of us would argue that's a good thing. We've got folks in the system. You go back to the clinicians and they're like, man, this is really hard. My workload has gone up, there's fewer folks to back me up, and the quality expectations and all the documentation has gone through the roof. And so these things are really creating this very hard tension right now of how we're navigating this to keep that level of quality and meet those level of patient demands while trying really hard. And this is one of the biggest topics on the mind of those executives right now is all right, I get that. How do I do that? And how do I do that in a way that makes this as kind and enjoyable as possible for my clinicians. And I think we'll talk about this more, I'm sure. Like, how do we get more folks just into the game in the first place, right? Like, how do I up the level of folks that are becoming clinicians or the non-clinical roles in healthcare? Because we need lots and lots of those right now.
I like the best of times, worst of times framing, and certainly I think appropriate as we look at it. And one of the things I'm excited about is kind of looking at what folks are doing as well as kind of what you see they have the ability to do. Maybe kind of one area to dip our toe into, we talked earlier today about kind of workforce disparities, the urban-rural divide, the challenges that presents. As you think about kind of clients that you're working with, of others in the industry, what do you see folks doing there to try to make some strides on that front?
Yeah, it's a really tough one. is the short story. And again, at the risk of telling a story that this room is familiar with, I think there's the things that make their way into the headlines, right? Of hospitals are greedy and they're shutting down rural centers, and is there some of that out there? Is there some bad behavior in certain pockets and on the margins? Sure. But fundamentally, what we're dealing with is, the raw economics and the raw pressures of the system, which is to say, when you expect a certain level of quality in healthcare, which we do, that means your physicians, your clinicians, they need a certain volume of services. No one wants to go, see the thoracic surgeon that's done 4 operations in the last month. That's not a good recipe for quality. You want the person that's practiced. Likewise, the economics of some of these systems, just don't work. Childbirth and OB is one of the ones that gets headlines a lot. We talk about these deserts of, the OB wards are disappearing across the country, right? But then you look at the economics of that. It costs something like, $10 million to keep one of these going, like a really small one going, and you think about the population that you need to make that break even, and that's a couple 100,000 people. In a place like the Triangle, easy. We've got that, right? Go to any major urban MSA in the country, we've got that. You start to get into the outskirts, and you draw drive time rings around this, and those economics start to break down pretty fast. You go to Montana, and good luck drawing a ring with 200,000 people in it that's got a reasonable 2-hour drive time to an OB center, and you can quickly understand why these places are going out of business. And so, that's the problem. What do you do about that? I think some of this there for sure has to be a government solution. And in my conversations with heads of HHS for various states, like California is starting to do this. We think of California, right, as being super urban, and we think of LA and San Fran, but most of California is farmland and almonds and trees, and this is a big problem for them, right? And so they're actually saying we will, just in the same way that we build highways and we build power lines and all these other infrastructure where there's no break even on that, right? There's no break even on a rural highway. We're going to infuse some cash and some money to just keep these open as services to those communities, recognizing our agricultural communities, they feed our urban communities, and we need those. So there's some part of this that's just structural. If you don't break those economics and cross-subsidize to a degree, it doesn't work. I think the other part of this is recognizing, back to the point I made earlier of volume and expertise. We need to do things to get volume and expertise into these places where you can't create it organically, right? So again, you go to far eastern California, other than maybe the Tahoe area, you're just not going to find enough people to make this work. So is this a place where we can use telemedicine to selectively infuse or import on a moment's notice the expertise that we couldn't grow in-house? Conversely, as we think about these large systems or partnerships between systems, can we have our clinicians round selectively, basically circuit ride out to these systems? Maybe they do a couple months a day there. That doesn't necessarily solve a birth and delivery problem, but you think about a complex surgery and it can solve that problem. The other part of this too is just that if you think about most of us, and maybe I'm a bad example because I grew up in the Northeast and I went to school here and somehow I wound up in Seattle, but that's another story. But most people want to work either where they grew up or where they trained and went to school. And so how do you move the training into these centers? Because if someone goes and they do their med school or residency at Chapel Hill, they're probably not the same person that's interested in going out and doing a fellowship or setting up practice in a rural area. So how do you move more of those residency and those fellowship programs, and meet that clinician who wants to live there and wants to live that lifestyle and see that patient pool kind of where they are, train them there to form those roots in the community where they're going to be more likely to stay put and serve that community.
I want to come back to the talent kind of acquisition and training front. I guess first, the infrastructure comment I think is a really compelling one, and kind of the role of how do we build out the healthcare infrastructure. And clearly, to your point, there's a governmental role in that. I'm curious, to what extent does the analogy work as we think about the kind of for-profit sector, public capital, private capital, as a means, take your highway, we have kind of standard highways. We also, have toll roads that are funded through other mechanisms. Kind of what sorts, do you see any creativity on kind of that infrastructure argument for others stepping in?
Yeah, I think so, and I think, Brad, it's different in different lanes, if you will, of the medical system. So if I take a pure, I won't incriminate any specific systems, but if I take the pure for-profit hospital systems that are known for kind of cranking RVUs and like doing as many procedures in a focused way, they're going to be the hardest to go down this path, right? Like one of those kinds of systems, like you really have to bend their culture and their way of doing business to get them to open a rural hospital. If I think about academic medicine, on the other hand, now there are some interesting synergies. If I'm oncology, I'll take my part of the world, the Pacific Northwest. If I'm a major oncology institute in the Pacific Northwest, there, even in my dense urban populated area in the Puget Sound area, there's only so many patients that I can get access to do a clinical trial. So now if I think about my universe as Eastern Washington, Idaho, Montana, the Dakotas, for me as that academic research institute, those are patients that I can get in my clinical trials, but they're not just going to show up on my doorstep. So how do I form relationships with those distant parts of the community, with rural primary care centers, with rural multi-specialty groups, with the less dense hospitals, so that I'm again importing my expertise to those, potentially exporting patients on a selective basis, and kind of everybody benefits because I get access to that raw patient population that my economics just don't work without.
That makes sense. Let me stay at the kind of governmental level for a little bit longer, which is, across your career, you've had the opportunity to work with different administrations and think about kind of the implications there. And so I'm curious both how you've seen those administrations change in their approach to healthcare and the workforce, and then given the change that we will experience here shortly, kind of how should we be thinking about the implications that will have going forward?
Yeah, this is a fun one, and I've had the both actually fun and not so fun in some ways. But I've had the privilege in my career of before the roles that you mentioned in my intro, I also ran. BCG has a sort of Center for Policy Analysis and Reform, and that was a really interesting role to run. I learned really quickly how to say something in a very neutral way, because if you edge in this country where about 50% of people were very happy with the election and about 50% were very unhappy with the election, if you say anything that strays outside of the median, people will send you visceral emails, you are a partisan, you said this thing, and you're biased. And so anyway, I had a lot of fun dealing with that for a few years. I've also gotten to meet, I've had the privilege of getting to meet some of the heads of HHS and CMS at the federal level for the states. And I have to say, the conversations with those folks are super interesting. And they're very different than the conversations that you have on TV. And I'll just say this, if you go read the Wikipedia page of any of those folks and what it says about their points of view and what happened in office, it is 100% wrong. It is just 100% wrong. So know that when you're trying to read the politics from the outside. And just to put a really fine point on this, I was just speaking with, I won't incriminate the person, but one of the former heads of HHS for California, and they said, I served at the bequest of my government and my governor cared about 3 issues. won't name the issues, but they cared really about 3 issues. Everything else, I got to decide. And if you think about it, so there's, the big things that we talk about of like what's going to happen with the ACA and some of the other reforms. And like, I don't like to predict the future too much. I would predict, in spite of some flurry at the end of the campaigns, we're probably not going to spend a ton of time on that. So outside of a few issues like that, so much of the actual inner workings of the government and things that really, really move the needle get decided by these administrators that, sit before Congress and get grilled a little bit. But other than that, and like Congress doesn't actually know the right questions to ask them because like very few people actually understand how any of this works. So with that backdrop, I think it's important to say there is far more commonality than not. Like if I just rewind, back to the Obama years, which was, the first part of my career where I was really in the game in a meaningful way. Again, other than the ACA, and there was a lot of debate and fierce discussion around that. You take that aside and you get into like, how are we managing Medicare? How are we administering CMS? How are we encouraging or not encouraging the use of electronic medical records? Far more in common across the Obama administration, the Trump administration, the Biden administration, and possibly a Trump 2.0 administration than there are differences. And so I think that's an important thing for everyone to remember is the idea that they're doing these like vast, huge swings is the hyperbolic story that we get on TV. That said, there are some really important things that don't get discussed as much, although if you've been following the stock price, you can see it in the stock the last years. Interestingly, I would say the Obama administration and the Trump administration had far more in common in terms of how they managed CMS and Medicare in particular than the Biden administration did with either of those 2 administrations. The Trump administration and the Obama administration were both very forceful in terms of encouraging the use of electronic interchanges, which like it's crazy. We still walk into any doctor's office or OR and like you'll still see fax machines and pagers. But there's been a ton of work behind the scenes by the administrations in terms of the regulation and incentives to encourage that. Likewise, the Obama administrations and Trump administrations really pushed heavily on using the STARS reimbursement. For those of you that are familiar, Medicare plans, Medicare Advantage plans have a STARS system. That actually influences very heavily the compensation that plans get from the government. Both of those administrations were, I would say, very carrot focused in saying, let's use those STARS to, reduce the burden that we're expecting our clinicians to have to encourage patient safety, et cetera. The Biden administration was much more stick focused and really said like, hey, there's a whole lot of like waste in the healthcare system and like we're really going to cramp down on reimbursement codes and to try and sweep that out of the system and then sort of like let the good physicians and the good health plans like rise to the top. I would say if you ask the average the average insurance executive or the average hospital executive or, and how that trickles down into clinicians, like that's actually probably felt less good, just given the stick versus carrot nature of the last few years. And so I think, again, at the risk of being careful of predicting, I think there's an expectation that we'll move more back into carrot mode in the next few years. And you might see, again, a more aggressive push to like, how do we really reward people that are taking work for clinicians out of the system, implementing electronic records and the like. The one call out I'll make on that because I don't want to totally paint a hyperbolic picture is I will say the Biden administration has been pretty aggressive via CMS of really trying to reduce the burden around utilization management, so these prior authorizations that a lot of us have to deal with, and that's been one place. But again, more stick oriented than carrot, stick specifically towards the payers, that they've been really aggressive in trying to reduce that burden.
So it's interesting to hear you unpack it. I guess one more question on this is how do you work with businesses to think about risk mitigation, given that, even if there's some indication of the trend where we might head, at the same time, there's plenty of uncertainty out there?
It's a great question. Simplistically, you have to have a plan A and a plan B at all times, right? And it's very few. I've seen very few companies like actually develop a really good plan B and have it ready to go in the back drawer if the policy changes or develops in a way that's unexpected. And so I'd say most companies end up doing something more like going 3/4 of the way to plan A, which they expect the outcome to go, But, keeping a little bit of lights on and, the back room on plan B. It's a very old example, but I'd say like outside of healthcare, you can see much better examples of this than in healthcare, right? Like for those of you that are old enough to remember the Toyota Prius, like that was a great example of like some executives sat around, this was, in the 90s when like, oil and gas were like free, and they were like, hey, what would happen if like gas got to like $5 a gallon? And they're like, that'll never happen, but what the heck, let's develop this, hybrid car that's like 3 times as efficient. And like, they did it, and everyone kind of stared at it and said, like, that was interesting until, like, 5 years later, and then, right, now we all know what happened, right?
Yep.
And I think healthcare is similar of, like, we need to keep pushing ourselves to say, like, okay, like, in a world where making something up, if we talk about physician education a little later, like, what if we, switched our medical education to look like Europe, and we effectively got rid of residency for primary care physicians? I don't know a lot of hospital executives that are actually like thinking about a plan B for that right now.
No, that's great. And certainly part of the challenge is, back to your point earlier, of kind of limited resources and time. And so kind of the slack in the system to support it while at the same time desperately needing it given the potential changes ahead. So let's return to the talent acquisition that you touched on very briefly earlier. And so, how do you see kind of healthcare organizations thinking about it, or how should they be thinking about it now, particularly kind of increasing need for skill, whether that's technology, whether that's thinking about this kind of customer demands and expectations point of how they're going about trying to build that workforce? Yeah.
Everyone is struggling is the short story, and some are doing it better than others, and some pockets are feeling it more than others. And I'll talk to these in kind of different chunks, but just to introduce the chunks to you, I'd say one of the biggest right now, which also influences the other parts of the market, is what's going on with AI and advanced technology. And this is a place where the potential unlock is very big. I also think we all should be cautious in this room. Like, we're not, 90 days away from like someone pushing a button and, GPT replacing a physician, right? But done the right way, AI and automation in general can really change the workforce and the quality of the work for our clinicians and patients. That said, like, healthcare is typically on the losing end of that battle, and I'll come back to that. And particularly interesting, when I was here in undergrad, there was like a software company here. It was like SAS. I'm sure there were others, but not big. And like now it's like all of the fangs, right? Like my brother works for Cisco, like Apple, Meta, like everyone's hanging around here. And so like that competition has come to here. So like pretty much every town in this country, every city in this country is feeling that. If I then move to the more clinical parts of the workforce, I think MDs is one where folks are really struggling, back to what I mentioned in my introduction of like there's more on their way out than there are on their way in. And systems are really thinking about this in a couple ways. And it's one that has to be de-averaged in multiple ways, right? And if any of you read, there was an article in the Wall Street Journal, I think it was about a week and a half ago, about the difference in generational expectations between more experienced clinicians towards the end of their careers and those that were entering the workforce. I think it hit it on the head pretty well. Of the folks that went to med school, pick a decade, 20, 30 years ago, the world that they entered into was totally different in terms of the autonomy that they had as clinicians. Back then, if you went into family practice, you saw your patients at the office, you rounded on them at the hospital, you covered the whole continuum of care. You probably owned your practice and made a whole lot of money. And, the work was really, really hard, but the rewards were huge, and the work was generally very interesting, and you didn't have to spend 20 minutes typing everything into Epic. Now, most physicians coming out of medical school, they're not going to be running their own practice. They're going to be employed for one of the major systems. They will be in a part of that practice. Pretty much nobody runs on their own patients unless you're a surgeon these days, right? And so that kind of 360 view is out of it, and the documentation requirements are huge. And so what makes someone at the end of career, in that, kind of first archetype versus new career, where most of the recruiting and hiring is happening now, are very different. And so what we're seeing is, really thinking about how do we create models that meet those newer docs coming into the system where they are? Because like just, hey, work 90 hours and spend 30 hours after your shift typing everything into Epic, like isn't doing it anymore. Like that's not exciting people, and like there's a lot of people that'll just be like, okay, I'll go work at a med spa, or like, you know, I'm guilty, like I've hired a lot of physicians at BCG that like don't practice medicine anymore. They'll come work for us or different parts of the sector, right? And so it's like, how do you create schedules and platforms and career paths for those folks that are engaging and exciting and stimulate them intellectually and do the things that brought them into medicine in the first place, but take that administrative burden off their plate and frankly take away some of the things that, like, when someone's not making $500,000 a year because they don't own their own practice, like they're not interested in, you know, those other parts of the job, right? And then there's the, you know, kind of clinical extension part of the world, right, which I'll like go all the way from like NPs and PAs into nurses, and really thinking about like how do we make those career paths exciting too. Also recognizing that, again, there's an interplay where the more we get those extenders into the workforce and we empower them, and again, there's a legislative angle here too, because some states, I think North Carolina too, is a little more restrictive in terms of what folks can do. But the more we get those extenders in, taking on additional tasks, acting closer and closer to doctors, the more that workload can be spread and the more the career model can be satisfying for folks. And then coming all the way back to where I started with this, right? Like AI has a pretty big role to play in this, right? Some of the systems that are like further ahead of the curve on this, Kaiser, as an example, you know, they've radically cut the note-taking time of their MDs, and like their MDs like that a lot, and that's translated into a recruiting edge for them, which is huge.
So a bunch of things to unpack in there. Let's take the comment about kind of work redesign. And so you mentioned scope of practice has a big role in there. But how do you think about bringing, you know, as an operations professor, kind of core operations and process improvement into redesigning who does what? And can you talk a little bit about kind of that experience, both the kind of promise and then the challenges that it's created as you've executed?
Yeah, absolutely. And as an operations professor, you'll probably appreciate this. It runs the gamut from things that like a non-operations person would look at this from the outside and go like, man, that's really boring. But you know, how you triage. That hurts, Nate. I love operations, so I'm in the nerdy camp with you. But you know, how do you triage patients, right? Like, how many extra rooms do I have so that while a patient's being examined in one room, the next room over can be empty? The next room over has a patient who's getting their blood pressure done, getting their vitals done, and so that they're getting into there, and there's kind of this flow through of the patients. You know, where we're talking about the automation and the Gen AI, right? It's like, how am I taking away that note-taking burden so that at the end of the visit, the provider isn't, you know, just sitting there like typing into Epic again sorry, I'm picking on Epic, Cerner, they could be typing into Cerner too, but, you know, typing into the EHR for, you know, 20 minutes at the end of the visit, and they're out doing, you know, things with their patients. And you can extrapolate those examples to, right, like the OR and, you know, more advanced settings. All that said, there is such a thing as too efficient. And, you know, one of the things we've seen in this work with systems is, you know, I'll go back to my, you know, advanced practice and clinicians example of, you know, some systems were like, we're just going to have everyone practice top of license, right? So like all the easy cases, we're going to have the PAs and the NPs do those, or like our younger physicians and like our, you know, really great physicians, we're going to have them practice top of license, and, you know, they'll do all the like dengue fever and the really, you know, Dr. House stuff that's like super complicated. Turns out that sucks too. Like if you're a doctor and you go in and all you have is like, you know, the average doctor sees, you know, something like 12, 15, like sometimes more patients a day. If like you get like 12 super complex, like messy things in a day, like you leave that office and you're drained. And so there is this tension of like, how do I make things more efficient, cut out the parts of the job that people don't like, but still give our people a mix of interesting and hard things so that their day feels, you know, varied and rewarding.
And that's great. Kind of, I think one of the challenges of any complex system, of which healthcare clearly is one, is the unintended consequences of change. That we can swing things pretty far accidentally in an attempt to do good. And so, how do we kind of keep taking those steps, mostly forward, occasionally back, but doing it in small, kind of thoughtful, improvement-focused ways? One other question. Go ahead. Yeah.
Sorry to interrupt. thought that spurred that, like, this one I think is actually like super fun because we just did this with a large orthopedic institute that focused on kind of complex joint replacements and surgeries. Was sometimes physicians don't know what's best for them. And we walked in and it was like every physician, every MD was like, this is the best joint. Like this one, it's made of titanium, it does this, it has this. And then you go to the next clinician and they're like, no. This one, this is really the one. It has this carbon fiber thing, and like the ball socket is this way, and like I love this, and the pin articulates at this angle, and so like my tech can put it in. Like you go down, and they all had their own thing, and like gloves, like oh my gosh, like if you want to pick a fight, like go into a doctor's office and be like, you know, we're gonna replace your gloves with a single brand, and like people will like beat scalpels out at you, but you go through that exercise, and then you get to the end of it, and they're like, oh my god, like. Now whenever I schedule an operation, like the knee is in stock because we don't have 200 SKUs of knees from like 30 different companies and 20 different sizes, and there's a change management and a big leap of faith because like folks really have their preferences, and none of the reasons they gave us were stupid, right? They were all really good reasons, and you know these were all extremely accomplished career professionals, but we had to get them to do this collective leap of faith, and then at the end of it was like, yeah, I guess maybe this is better, and like actually like you know going into the stock room and just knowing that it's there.
Yeah, right. Or on some of these, maybe it's not better, but it's not worse, and there's kind of big savings on the back end, right?
Totally.
And so I think your change management point's a huge one. You've talked about kind of better acquiring existing talent. How do we kind of set the processes up to function more effectively? But how about approaches to generate new talent, of taking folks and finding ways to kind of create your own talent within the organization?
Yeah, that's a great one, and yeah, finding that talent within. You know, so many organizations that we work with really struggle with this one, and one of the things that like many aspects of medicine lack, if you compare it to you know other industries or other parts of the world, is you know sort of this internal concept of upward mobility, right, and really having career tracks for folks. And part of that's for good reason. Again, medicine is. Quality is super important. We have to be regimented. We have rules and you know processes for very good reasons. But yeah, it makes it when you get too many of those rules and career tracks are too fixed, or it's like, well, you can stay in this role until you do you know 1 million hours of CEEs and you know go and get 4 more degrees, and then we'll let you do this other thing. You're both holding good people back. And you're making them feel very frustrated because it's hard for them to see, like, you know, how am I going to make a difference in this organization? And so one of the things we've done is really worked with organizations to say, how can we, you know, without breaking any rules or having someone do, you know, operation they're not certified to do, but how can we create, you know, career tracks within the organization, both on the patient-facing side. It's important for folks that are seeing patients to understand, like, okay, this is how my job will evolve and what the next thing is, as well as for the folks that are maybe more internal facing and thinking about the administrative side, like what can that look like, and creating that kind of fluidity and upward mobility can really up the quality of leadership. The other thing, and like this is the less fun side of this, but also being really honest with folks about like who's kind of peaked or who's plateaued within the organization, and we call them blockers of you have someone that's been in upper middle management role X for 20 years. Maybe they're doing a good job, but the fact that that person is there and they're there for so long, all of the people under them are effectively trapped and will probably leave the organization as opposed to finding a more senior role or having a voice in your organization. So figuring out ways, it doesn't necessarily have to be out, but figuring out ways to force some shuffling so that you're not having folks that are blockers in the organization, you're creating those upward paths.
Yeah, no, it's a great point of kind of getting into understanding it and then having those hard conversations to create the opportunities. Somewhat in line with that is thinking a little bit about the non-clinical workforce. And so it's certainly a topic we see written about a lot. It's seeing kind of an increase over time of more folks taking on kind of these roles. And so I'm curious your thoughts on kind of where do you see that as it's really important as it helps drive efficiency? Where do you see it maybe gets in the way of some of the patient interaction and drags things down as well? Yeah,
this is one I'm particularly passionate on, and I'll tell you all a little story of kind of why. I will admit that until like 6 or 7 years ago, like I was kind of ignorant to the non-clinical parts of the workforce. I mean, I knew they were there, like I knew they were doing important things, but I didn't realize how important they were. And we did a project for a large insurance company that was, you might call them a payvider. They also, employed a lot of physicians and had their own clinics. And they were really struggling because their readmission rate was much higher than they wanted it to be, much higher than our friends at CMS wanted it to be. It was hurting their pocketbooks. They were just, there's obviously a lot of bad things when folks are coming back into the hospital. And so we did a pretty comprehensive study of like we were lucky that this was a payvider because we had great data of like what was happening along the way. And so we basically, did a real world evidence trial of like what's going on with these folks, like what are the different interventions. And it turned out that, the going in hypotheses of, like the folks that were, coming back in and being readmitted, like, well, we probably discharged them to the wrong setting. They went home when they should have gone to a SNF, or maybe their discharge plan wasn't good, or there was, we had a never event, or, there was a, HAI hospital acquired infection, something like that. And like, yeah, those things were there, but they were really the margin cases. The biggest thing that determined whether someone was going to come back in was whether they were getting quality meals at home and whether they had someone in the house that could help them take their medicine and make sure that they were just doing the very basic things that one does when you have to recover after the hospital. And that's not a doctor's job, right? That's not even a nurse's job. And so we basically discovered the answer was home health aides. And these other very important non-clinical roles for folks that weren't fortunate enough to have a stable home situation or have someone else in the house, to basically have these non-clinical home health aides and others come and visit them and make sure they were doing all those things. And that radically transformed the readmission rate. Also, if you look at that population I just talked about, they have the highest turnover in healthcare by almost an exponential margin. I think home health aides are 65-ish% annual turnover. It's just it's horrific. And it sort of gets back to I don't think the system collectively has recognized the important role that those folks really play in medicine. In this case, more important than the doctors or anyone else. And so similar concepts to what I described earlier of, how do you think about your leadership talent? These are positions in particular that have no career path, often are not at the great side of the pay scale, don't have great benefits. And so, really getting systems to rethink that and, how they reward these folks, how they give them, everything from scheduling to, time off in ways that are flexible and meet the folks that want to do these jobs where they are in ways that make them feel included and want to stay there.
I'm curious, one thing as you were talking that struck me, so you mentioned kind of the payvider meant that you had really good data you could look at. And so for a lot of these things, kind of you're stepping in sort of a change management role. And you're studying these problems carefully, and then eventually one hopes, the client's taking it and making some change. And so can you talk a little bit about that process and the continuum from, I'm sure there's some gold standards that are kind of really thoughtful, you build the ROI and they're wonderful, we do it, but there's got to be a whole bunch in between. And so how do you drive change, and how do kind of the audience think about driving that change when folks are if it doesn't save me money today, not going to do it?
Yeah, it's it depends a lot on the system and what population you're dealing with. And I will say, just to call it out, you heard in my early example, doctors are really hard to change. They really don't like to change. And so, I find with a true patient-facing, clinical MD population, you've really got to show them. You've got to set up pilots. You've got to do proof of concepts. You've got to spend the time, and for good reason, right? These are very accomplished people. They've, spent years getting their education, years in patient practice, and part of why we hire doctors to do what they do is we need people to make these instinctual decisions, at critical moments. And so getting them to overcome that and show them the data and then show them an alternative is really important. And every time I've had a team or worked with a client that's underestimated that change management burden, it's been a failure, or it's been, take one, failed, and then we had to come back and, do it a second time. I do think the flip side of that is, I find most healthcare organizations, like, money matters, right? Like, it matters everywhere. So having a good business case helps. It helps more in a for-profit public company than it does in a not-for-profit. But it still matters a ton at the not-for-profit. But like everyone in this space, like, there are all easier things we could have chose to do for a living, right? And so if you speak to them of the mission and the patient outcomes and like what this feels like for the community, and like what that end state looks like, that's almost always a successful formula, right? Like nobody in this space, if you say, hey, even if the business case is net neutral, and even if the workload is going to be the same tomorrow, if you put this in front of them and say like, hey, you're going to have happier patients, you're going to have higher clinical safety, you're going to have better outcomes, like I've not seen too many organizations walk away from that.
That's good to hear. One more kind of topic area I want to return to, and then I want to open it up for questions from the audience. You've touched on AI kind of and technology, and it's certainly been a theme that's kind of run through the day so far. But as you think about the future of the healthcare workforce, can you talk a little bit about how AI and technology kind of are going to shape that?
Yeah, I have to say I was. I don't know if skeptical was the right way of describing it, but like until fairly recently, I thought at least the near-term impact of AI was being overblown. And one of the reasons I felt that way is I think there's sort of this narrative in healthcare of like, oh, we're so backwards and like nothing's automated. And again, as I talked about, like you go and you see fax machines and beepers, and it's really easy to be like, oh, like everything's in the dark ages. But then you go behind the scenes and you realize like not Gen AI, but like actual automation is everywhere. Payers are automatically processing claims at greater than 90%, and like some of these claims are really, really complicated. So we've gotten to the point where very complex amounts of paperwork that used to take gobs of humans, like those are already being automated. And so when folks walk in and they're like, oh, this is going to totally change the game, and I'm like, well, this stuff is all like already automated, right? So like, what are you going to do? Get 2 more percent? That's the place where I'm seeing some really, really powerful things is in outright human replacement. And I sat for a demo just a couple weeks ago. We had our offsite event with about 70 C-suite members, and a parade of AI companies came in, and I'll be polite but honest with this group. Like a bunch of the stuff I saw was kind of like, like okay, like you've automated some note taking, that's cool. You've like popped a flag and said like don't give this patient who has tachycardia a calcium channel blocker. Like okay, cool, like all right. But then there was another company that replaced, if any of you have ever had a procedure going into the hospital or kind of know this part of the continuum, pre-op, you get these phone calls and they say, all right, you're going in for this procedure, like do this, wash with this antibiotic soap, don't eat these things, et cetera, et cetera. That takes a huge volume of nurse time, and it's not a super fun thing for nurses to be doing. The company I saw replaced that. I don't mean augmented, I mean replaced. A computer called all of the patients, and we listened to phone calls of the interactions with the patients, and it did all of that. It asked them all the questions. They asked it questions. They were like laughing. They said, are you a robot? It said yes. And so like, and then after they laughed, then they were like, okay, I've never talked to a robot before. Like, tell me, like, what's it like to be a robot? And it would like answer that, and then they would say, okay, but can I have soup before my operation tomorrow? And then it would just go through all this, and it would complete it. And of course, there were bounce outs if someone really had something truly clinically concerning. But that was like less than 0.25% of the phone calls. And so, this AI tool is now replacing, back to this like the not fun parts of the job, like is replacing loads of the not fun parts of the job for nurses, and those nurses can now go on and do other things. And so I think we're really going to see that type of technology changing the game. The other thing that I like, to me, and I don't think this has gotten talked about nearly enough, at least not in the right context. It does, but wearable technology and just the advancements in terms of ready clinical informatics. Like the average person who has, a Garmin, an Apple Watch, like pick your device, like there's more clinical data available to you in your house than existed full stop in a doctor's office in the 1980s. And so the ability to use that data and perform like true diagnostic telemedicine, like we're rapidly coming up a steep curve. And you just think about the remote telemetry and what we can do. And so I also think between that and AI, there's a load of stuff that we do in a doctor's office today that is just going to be done, from your house when you wake up in the morning. And if I get really crazy and I like intersect that with personalized medicine, right? Like we're not too far away from a world where like, if your watch tells you something is off, like you spit into a cup, you send it in the mail and they're like, oh, here's your personalized drug. So like those, that I'm being a little hyperbolic there, but like those things are like just radically going to transform like what we actually spend our time on in medicine. It's going to be far more interesting in complex things.
Yeah, no, I mean, I think it's an awesome story to kind of hear you or kind of see the picture that you're painting and thinking about that. I do think I approach things often in terms of trade-offs and appreciating kind of the balance that comes, right? And I think it is worth, while personally incredibly kind of techno-optimist, I also would say kind of if you bet the over in healthcare on technology and timing, I doubt it hasn't cashed yet. And so, take actually that story of, yes, headed in some really good places, recognize that we've also throughout the day spent a whole lot of time highlighting the challenges with EHRs, right? And in many ways, AI, right, is just the current form of technological change, right? And so we've done lots of technology changes. You're highlighting lots of good, some challenges, and so a couple steps forward, one step back. And we think about these tools that it's awesome. We can code more accurately. Tools can be used for positive purposes. We take work off people's plates. They can be used for more challenging. We upcode, and now suddenly we distort payment models even more as we look at this. And so I think it's how do we take these on that workforce front? Yeah, we want to replace some of those things. We also want to augment, but frequently we can create more work inadvertently too. And so that whole system design is a big deal as we approach it. I want to open it up to questions. I have more, but to throw it out, and so I think we've got some help if you want to. Great, find, yeah.
What do you see in terms of AI's impact on medical imaging? Talk a little bit about how it relates to, a virtual assistant for triage, and some of the things it's doing more with LLM impact within medicine. But what about the imaging modalities like MRI, CT? Obviously, AI is very good at pattern recognition.
Yeah, 100%. I think we will pretty quickly get to a place where the humans will be minimized in that equation. I mean, if you look at where the advanced imaging models have come, probably a bunch of folks in this room know this, like most folks outside of this room may not. Like very high percentage of the time, like you get an imaging in a hospital or freestanding center, it's not being looked at by someone in that building anymore. It might even not be looked at by someone in this country. It's getting, put in a pipe going to, India, the Cayman Islands, wherever centers of excellence, getting analyzed there, getting sent back. Now, to your point, we're then augmenting, or in some cases, we're not replacing yet. I don't think too many people are comfortable doing that, but I think we'll quickly get to a place where the human review is, vastly reduced, much in the same way that, today, we don't really think about this as automated, right? But if anyone gets a blood test, if you go and you get a CBC or a, comprehensive metabolic panel, there's no human that's doing that, right? Like it goes in a tube, it spins it around, Quest or LabCorp like analyzes it, the computer spits out the results, and it goes back to the physician. And no one is like, oh, a computer has done your blood test. This is scary. Like we're all just used to that, to the point where we don't even think about it. And I don't know exactly how fast we get there, but I think we'll get there with imaging too.
Hi, I'm Neharika Kadali. I'm a third-year undergrad studying health policy and management. A lot of what I've seen at the intersection of health and business seems to be kind of like a misinformation between like what the business side can do for healthcare and what health can do for business. So how do you go about operating in that dynamic where like healthcare individuals may not think you really know what you're talking about because you come from like a non-clinical background, but then how do you like also kind of put your like foundation and integrity down to ensure that you inform those that you're working with that you do kind of have an understanding of the healthcare space?
Yeah, it's a great question. I mean, simplistically, like, and I'm lucky, I have lots of teams that work with me. So, like, typically when I go to a conversation with MDs, I'll bring the MDs on my team. But like, if you want to be in this world and do this type of work, like, you've got to be able to hold your own, right? Like, if I couldn't talk at least semi-clinically, I usually apologize to my doctors because I'm like, I'm sorry, I'm like semi-clinical, so I'm gonna like say some things that sound smart, and then some other things that you're gonna look at me and be like, dude, you're an idiot. But you've got to at least like know kind of what's going on and what the life of a doctor or clinician is like to put yourself in their shoes and understand. I think far too many things in healthcare, and some of the hyperbolic ones, like they, I'll pick a great example of this. Was like 10-ish years ago now, of like in the early days of the ACA, a whole bunch of Silicon Valley companies got really excited and started up all these like small consumer-centric insurance companies, and they're like, oh, like payers don't get it, like they're stupid and they don't understand their customers, and so like we're gonna set these up and like they're gonna be so cool and like they're gonna take off. And it's like, actually, no, like insurance companies like actually understand their customers really well, and they actually understand that for the most part there's not a lot of money to be, this is unfortunate, but there's not a lot of money to be made in being very consumer centric in an industry where they do worse if you use your benefits. And so like most of those startups fizzled because, you know, kind of the, you know, the right brain and the left brain, to your point, didn't talk to each other. And so in order to make models that work, like you really need to understand both.
Thank you so much for your remarks. It's great to have you. So you actually just touched upon part of my question, which is when we think about some of the challenges and opportunities with the healthcare workforce and thinking about multi-stakeholder opportunities, given your role at BCG, are there any best practices, insights, opinions about how the payer stakeholder could be part of the solution?
100%. And at the meeting I mentioned a couple minutes ago, where we had all these C-suite folks in the room, it was super interesting because usually those types of conferences, it's either like a bunch of hospital execs or it's a bunch of insurance execs, and you know they kind of live in their own worlds and, you know, complain about each other even though they need each other. And at this one we had both of them in the room together, and there were some really respectful but really pointy exchanges between the insurance execs and the hospital execs that I will say there's a lot of misunderstanding between the two parties of the economics of the other party that penalizes everyone, frankly, because a lot of the discussion, you know, in the world to date, or in the US to date, is, you know, the payer sits and they go, well, I have this many patients, or I have this many members, and therefore, like, you should give me a low rate because I have all this bargaining power. And the hospital sits on their side and they say, well, I have this many hospital beds, and like you can't possibly operate a network without me, and so like you need me in network, and so like you're going to pay me this rate. And that's a zero-sum game, right? Like nobody really benefits in that equation. And interestingly, if I bring this full circle, I think the capacity shortfall in the system is actually forced a different discussion right now, because now there's no world in which we don't fill every hospital bed, basically, right? Like they all get filled, every physician office is filled, and so like there's less of a volume driving discussion, right? Like we don't need to have that discussion as much, because like the doctors are sort of naturally going to like triage the highest cases, and you know, again, there's always some bad actors, but like mostly that's just going to like sort itself out. And so it's actually forcing the payers and providers to listen to each other and say like, okay, like what does good economics look like for you? Like when I change this policy, how much does it cost you? But like actually bringing those parties together and like forcing them to have that exchange in a world where there hasn't been loads of historic trust has been difficult. But ironically, I think this world of scarcity that we're living in is driving that dialogue in a more productive way.
So we're calling out a lot of issues and the need for innovation, but it's a historically slow to adopt innovation because you don't ever want to mess up, right? There's a lot of rules, regulations, events can never happen. How do you bridge the gap? You know, government is probably the one thing that can start to break down these barriers.
Yeah, it's I'm going to steal something from Atul Gawande. Some of you might have read this in his book, but he talked about the rate of adoption of anesthesia versus the rate of adoption of antiseptics. And for those of you that don't know the story, when anesthesia was first developed, like prior to that, this is like horrifying, but like surgeries were done without anesthesia because it didn't exist. And like once anesthesia was invented, physicians adopted it like overnight, like being slightly exaggerative, but like it was literally we went from like no anesthesia to like 100% anesthesia in like a year globally before like we had today's like, you know, global travel structure. And the reason for that was the immediate instant feedback of doing that was so powerful for the physicians of I'm going from this patient screaming and writhing around on my table to an unconscious patient that like now lets me do the operation better, and like they feel loads better about it. You know, fast forward like 25, 50 years to the advent of antiseptics, you know, antibiotics in the modern environment, and the implementation of like holistic antibiotic usage, you know, perioperatively, like it took decades because that immediate feedback mechanism wasn't there, right? Like the doctor would do their operation, it would go great, and then like the patient would, you know, leave the OR, and then like a week later they'd go septic and they'd wind up in someone else's ED, and like it wasn't the doctor's problem. And so like bridging that like took a lot of work. So back to your question of like, in order for the innovation to work, we have to pull the reward of the innovation really close to the stakeholders so that they feel it feels big, and they feel it immediately. You know, having these sort of like amorphous, yes, everybody wants to do good, as I said earlier, but like the more amorphous and distant the rewards are, the harder it is to get change. You know, back to the orthopods I talked about earlier, right? Like switching out their joint. In order for us to make that work, like we had to make the rewards of that like very palpable to them in terms of the economics and the impact on their comp and the other metrics that they were looking at.
Hello, thank you for being here. My name is Shaista, and I'm a first-year MHA student. And bridging off of that question about the pace of innovation and adoption, we have a lot of discussions about a lag in regulation and essentially just AI governance policies that address and keep up with the pace of innovation that is in the AI space right now. So what are your thoughts on essentially ensuring when it comes to healthcare, how do you ensure risk mitigation, the ethics behind it, as well as ensuring that the patient-provider relationship isn't impacted by the AI adoptions?
Yeah, it's a great question. I may give you full warning an unsatisfying answer because there's a lot of I don't knows right now. If there's one thing that gives me comfort on this topic, it's that in healthcare we are naturally conservative and we naturally lag the rest of the universe when it comes to this. And so other industries and other professions are like figuring out what can go wrong before we are, and I think naturally systems are you know kind of in a bit of a wait and see mode in terms of what can go wrong. Honestly, I think in terms of the regulations around it, like we honestly don't know yet because we're in such early days. We can contemplate the things that can go wrong, right? Like obviously a misdiagnosis. But like if an AI misses a diagnosis, like who's accountable for that? Like what does that mean? And if you look at the other places where we're really getting into automation, you know, automated vehicles and driving as an example, like those questions aren't answered in that space either, right? Like San Francisco is probably the furthest along of any MSA in the US in terms of allowing automated taxis, and like they like every time an incident happens, they kind of like stop and look at each other and say like, what do we do? So a long-winded way of unsatisfactorily saying, we're going to need it, we're going to need to figure it out, and I really don't think anyone knows yet.
Great. Others can turn back to me. So one question I'm curious about is around retention. So we talked about how kind of bringing folks in, how do we develop, also how do we keep? And so what are you seeing on that front of organizations doing to try to retain the clinical and non-clinical workforce?
Yeah, we touched on some of these earlier, and it's just as important, right? Because if you do all these great things, to your point, on the acquisition side, just for folks to go out the door the next week, like that's probably not the best use of anyone's time or money. But I will say some of the tactics are probably similar in terms of right having the career paths. I also think really like collectively, like the whole healthcare system probably needs a rethink on scheduling. Like when we dive in, that's one of the biggest dissatisfiers of clinicians and non-clinicians. And it's like, it's bluntly, it's kind of inane. You know, it's been like, there's so much of like, this is the way that we did it, you know, way back when, and then piling like many years of incremental changes on top of that. If any of you have ever heard, I won't retell it because it's long, but the story of like people that like would slice the end off their ham, and like the kids would be like, why do you slice the end off the ham? And cutting to the chase of the story, it was because like when electric ovens first came out in like 1930, like ovens were super tiny and a full ham wouldn't fit, but like no one remembered that was why their grandparents sliced the end off the ham. They just did it. So much of healthcare scheduling, it's like that. It's like, well, why do we have call that way? And it's like back to the days of, again, when like family practice physicians would like round on their patients, and we don't do that anymore, but the schedules have not changed. So I think there's going to be a lot of that. Like another anecdote I'll use, this is actually from a friend of mine that lives across the street. She's a PA, and she's gone part-time because her kids are in school and she wants to spend extra time with them, and she still wants to work and be part of the workforce, and we badly need PAs in Seattle, and so she's trying to work. And she is per diem because the system that she works for, if they were to hire her part-time, they would put her in the regular vacation pool with all of the other PAs, and she would have to work the weeks that her kids were off of school. Like non-negotiable, like that's the policy, like everyone just has, so she's not gonna do it. And so like they are literally paying her like 2x what her part-time rate would be on a per diem basis, and she's working a third of the time, as opposed to like somebody sitting back and saying like, wait a second, like what are the things that are like common about people that want to work part-time? They're probably working part-time because of their kids or because they're later in their career. So can we actually like design a part-time model that's around them? And then the folks that like don't have kids and actually don't mind working those weeks, like but nobody's like, I shouldn't say nobody, very few people are like actually stepping back and in sort of a zero-based way say like, all right, forget however medicine was in 1930, like, or 1950, like, if we designed it today, what would it look like?
That's great, and that sets up last question for you, which is really looking forward, right? And you can pick the time frame you want, 5 years, 10 years, but as you think about kind of the future of the healthcare workforce, kind of what changes do you see? What would you call attention to?
Yeah, if I started talking a little bit about this in my space age future with like home genetic tests and personalized medicine. But this is you can like put this in a time capsule and bury it under a brick outside and see if I'm right. I suspect in like 20 years, give or take, that we're gonna have like a U model in the healthcare. And what I mean by that is like back to my example of just home health aides being really critical and folks not readmitting. I think we need a whole lot more of just non-clinical work to do the basic needs. I'll save this diatribe for another day, but like the problems that we have with metabolic health in this country, I mean, it's awesome that we've got GLPs and some of these new drugs now, but like 95% of that problem could be solved outside of the healthcare system, right? It's a problem largely of lifestyle and access to quality food and other things. And so like a lot of that like requires non-clinical solutions to solve. At the same time as the more and more of the like basic or easy parts of medicine get automated, we're going to see the job of the clinician getting more and more complex in terms of what we still have the humans do. And so just like we've seen in a lot of industries in a lot of places, I sort of think the middle tier of complexity is largely going to get hollowed out over time.
Great. Well, Nate, appreciate you joining us. Thanks for the discussion.